A very good evening and welcome all. This program is presented by Maharashtra IP. I welcome you all on behalf of IP, all CIP members, delegates, executives, office bearers, respected speakers and dignitaries. So this session of decoding vitamin D. So let us know something more about vitamin D today. Myself, Dr. Sonali Shirbhate, Executive Member of IP 2022. I welcome you all. Once again, I welcome President Dr. Hemant Gangolia sir, Secretary Dr. Amol Pawar sir, Convener Dr. Jay Bhandarkar sir, and our esteemed speaker Dr. Ganesh Jewadikar sir. We will be knowing more about him in further session. First of all, I would like to welcome our President Dr. Gangolia sir for his inaugural address.
Thank you, madam. Good evening and namaste to the respected dignitaries on this Zoom dais. Our guest speaker, Dr. Ganesh Jewadikar from Saket, New Delhi, and our state convener, Dr. Jay Kumar Bhandarkar, as well as moderator, Dr. Sonali Shirbhate, who is also co-chairman of the IP Women Committee, as well as Dr. Neha Singh, who is the editor of the IP, and all the viewers and all the attendees on the viewer link watching this session. Today's session is, as stated, decoding vitamin D. For last almost 8-10 years or a decade, I can say, there was a lot of knowledge about vitamin D. Some said it's a hype news. Some said every disease has something to be correlated with the vitamin D. So almost everybody started doing the levels of vitamin D, so deficiency, and most of them found to be deficient in that. How much it has a role to play, and almost we are seeing the prescriptions of vitamin D almost in all the prescription ranging from pediatric to geriatric. And then, of course, whether it's really needed or it's what is its role in so many diseases stated, ultimately coming to this, vitamin D should be given, vitamin D should be given. This all will be enlightened by our guest speaker, Dr. Ganesh Jewadikar, who is from New Delhi, and hope so he will just decode everything about Arachidol and on this vitamin D. And we have gone through the phase of while starting practice from massive doses of vitamin D to now whatever the recommended doses. And let us see how we can bring this use of vitamin D in our practice, which will be useful for our patients as well as for us to make us healthy. So surely this will be an enlightening session. Thank you very much.
Thank you very much, sir. Really, every prescription nowadays is loaded with vitamin D doses. So it is very important to all of us to know more about vitamin D. I would request our convener, Dr. Jay Bhandarkar sir, to have a few words. As our secretary is also busy in some another program, I would request Dr. Jay sir for his few words about this program.
Thank you, Sonali madam. And at the outset, I welcome all of you on this very important, I can say, subject or topic, vitamin D. Already stated by our Dr. Hemant, President of IP. So it is, we should not use the basic vitamin D, which is maybe deficient in the mother milk. We have to start supporting or giving the baby cells from the birth to up to 15 months, 18 months. And you see that a lot of studies are there, so much variations in a lot of studies, and when to call it insufficient or sufficient, and that to be which regimen should be given, whether a single dose or every single dose or 60,000 units every week for 6 weeks, and how much to give, because as a pediatrician we face a lot preterm based from 1 kg to almost nowadays due to corona, which is the babies of 60 to 70 adolescents. So, and this vitamin D is not role in the calcium and phosphorus or bone, I can say, metabolism. Rather, it is present in the LRTI, bronchial asthma, there's even atopic asthma, lot of cancer, even malignancies, static is helpful. So, I am very confident and see that our beloved speaker Dr. Ganesh Devdikar from the Mumbai, Delhi, is going to highlight or give the, I think, wisdom of pearls of this very important topic, that vitamin D. And we're going to address all the current guidelines. What is the studies going on in the world and what should be done for our important pediatric patients? Because as a pediatrician, I feel very pride to we see that we come in contact with all families and we take care of that child since the birth. And that initial years are very, very important for the child's development, and it's let us I cannot forget that all the science which is coming going to be very beautiful in next 1 hour. So I welcome again Ganesh sir, and thanks all the audience also for joining in large number. Thank you.
Thank you, sir.
Dr. Sonali, just a minute. Dr. Jay, as well as Dr. Sonali, on behalf of Maharashtra Academy of Pediatrics, we would like to thank Cachet Pharma for giving an academic grant for this very important scientific session and talk, which is on vitamin D. And this is the second time they have supported us. Last episode was all about iron. This time we are having all about vitamin D. And we hope that Cachet Pharma will continue to support and promote all these academic sessions in future also. Thanks to them. Thanks to Cachet Pharma. Yes, sir. Thank you, sir. Thank you, madam.
Thank you, sir. Really, what we know more commonly about vitamin D is it's fat soluble vitamin. It's more important in absorption of calcium, magnesium, especially bone, and its deficiency leads to like osteoporosis, rickets, and everything. So let us know more about and let us decode this vitamin D. First of all, I would invite our esteemed speaker today's pediatric endocrinologist, Dr. Ganesh Devdikar sir. Dr. Devdikar sir is MBBS, MD, DNB Pediatrics, and he is pediatric endocrinologist. Presently, he is at Max Super Specialty Hospital, Saket, Gurgaon. He is Secretary Treasurer of ISPAE, Indian Society for Pediatric and Adolescent Endocrinology. He was senior consultant at Medanta Medicity Hospital, Gurgaon. So let us know more and decoding about vitamin D. I invite Dr. Devdikar sir. Welcome, sir.
Thank you so much for a warm welcome, Maharashtra AOP and Dr. Gangulia and Dr. Sonali and Dr. Jay. Actually, I'm not from Delhi. I'm from Latur. I will always be from Latur. I'm just staying in Delhi and working in Delhi. I am going to make an attempt to, I don't think for any single person it is possible to decode vitamin D. But what I'm going to do is do some review of the existing literature and try and answer some common questions. I'm going to share my screen.
By the time sir shares the screen, all the viewers can post their questions in the chat box on the viewer links. Please do that. We'll take up that question after the session.
As Dr. Hemant said, we have been discussing about vitamin D over the past many years, past several years. Then why is it that still we need to decode? What has changed? So in the last few years, there has been increasing awareness of existence of vitamin D deficiency. We have come a long way where researchers maybe 20, 25 years ago or 30 years ago used to really struggle explaining people why, how come in India, which is abundant sunshine country, how come we have such massive amounts of vitamin D deficiency? And there has been awareness about role of vitamin D beyond bones. If we remember in practice for a long time, there was only araquitol injection and calcirol sachet for a very long time. But in the last few years, practically every single pharma company is making vitamin D formulations in different names and different strengths. Increasingly, the testing has become available. More and more people are being tested for vitamin D deficiency, some for valid reasons, some for all sorts of reasons. And also, everybody considers themselves to be an expert in vitamin D. So it is nobody's child. It is a vitamin, it is a hormone, it is a orthopedic surgeons, baby, physicians, rheumatologists, and everybody, gynecologists. So that causes a lot of confusion. and also sometimes causes multiple prescriptions. So therefore, just like malnutrition and obesity, we also have to be now tuned to orient ourselves to deficiency as well as toxicity of vitamin D. So over the next half an hour to 40 minutes, we'll go through some of the basic physiology of vitamin D, see some studies on prevalence of vitamin D. We'll talk about testing, prevention, and we'll take help of few case scenarios to understand the treatment and toxicity of vitamin D. Talking of basics, when we say vitamin D, basically we are referring to D2 and D3, ergocalciferol and cholecalciferol, and some other compounds which have similar structure. Basically, a cyclopentano perhydrophenethrin ring, which is common to steroid hormones. Basically. Now, some intelligent people can question why is there a D2 and D3 and why there is no D1. So actually, originally when vitamin D was discovered, the original discoverer, Dr. Windaus, he found 3 compounds, D1, D2, D3. But subsequently, the D1 was found that it's not an individual compound, but a mixture of several things. So the D1 term was abolished, and D2 and D3 were not promoted. They remained the D2 and D3. Now, vitamin D2 is basically ergocalciferol, which is obtained by ultraviolet irradiation of ergosterol and is found in sun-exposed mushrooms. In Western countries, ergocalciferol is also available as a pharmacological supplementation. And vitamin D3 is the one which is synthesized in our skin from 7-dehydrocholesterol. And is present in oil-rich fish. Here it is very important to remember that calcitriol or 1,25-dihydroxy-D is not the same as D3. So this is also important when we order the vitamin D test, because this compound is the active hormone or active form of vitamin D, which is synthesized in the kidney by the action of 1-hydroxylase enzyme. So calcitriol or 1,25-dihydroxy-D is not the same as D3. D3 is cholecalciferol. Vitamin D, as we know, is synthesized in our skin by the exposure of ultraviolet light of a specific wavelength, 290 to 315 nanometer, from a precursor called as provitamin D3 or 7-dehydrocalciferol, 7-dehydrocholesterol or calciferol. It is converted into pre-vitamin D3, and which is subsequently converted into vitamin D3. Both these reactions are not mediated by any enzyme or anything. It is just a photoisomerization. So subsequently, this vitamin D, now what will happen if we are excessively exposed to sunlight? Even if we are excessively exposed to sunlight, beyond a certain limit, the vitamin D3 synthesis does not happen. The pre-vitamin D3 is then converted into inactive forms of vitamin D if there is excess exposure of sunlight. So excessive exposure of sunlight will never lead to vitamin D toxicity. This vitamin D in circulation binds to D-binding protein and is taken to the liver, where it undergoes 25-hydroxylation, which forms the 25-hydroxy vitamin D, which is the form that we measure in our pharmacology in our laboratories. 25-hydroxy D subsequently undergoes 1-alpha-hydroxylation in kidney and forms the active hormone, that is 1,25-dihydroxy-D. The predominant action of calcitriol or 1,25-dihydroxy-D is to increase the absorption of calcium from the gut. That is the principal action. And some other actions are also increased reabsorption from the kidney and deposition of calcium and phosphate in the bone. So that is how vitamin D is important for mineralization of the bone. Now, over a period of last few years, it has been recognized that vitamin D receptors are expressed in several other tissues other than the bones. And therefore, that led to kind of interest in the non-skeletal actions of vitamin D. And practically, you name the condition and you will find studies which say that vitamin D is deficient in type 1 diabetes or cancer or autoimmune disorders, tuberculosis, so on and so forth, asthma, psoriasis, and several conditions. So it may have important role to play, or it has probably important role to play in skin proliferation of skin cells, innate immunity, immunomodulation, cancer prevention, blood pressure regulation, blood glucose control, and several other conditions. However, we must remember that when background prevalence of vitamin D deficiency is very high, you may find an association of a particular condition with a disease. So vitamin D deficiency with a disease. But association merely does not prove causality. And that is the main challenge that is there in terms of seeing whether vitamin D supplementation is beneficial in these conditions or not. So as of now, the current evidence does not support treating or supplementing vitamin D just for these conditions, because a causal association of vitamin D deficiency has not been proven for most of these conditions. What are the sources of vitamin D? Practically the only source of vitamin D for us is, only natural source is sunlight exposure. We'll go into the details of sunlight exposure. The other sources are fortified foods. There are some availability. There is some availability in the past few years of fortified milk. For example, Mother Dairy toned the token milk, or Nestle A plus milk, or similar options in Amul milk also. Some juices or some breads or cereals may be fortified with vitamin D. Now, in terms of fish, the fish which are vitamin D rich are very scarce in India. So therefore, typically the fish like salmon, tuna, mackerel, etc. are not predominantly taken in India. And also eggs have a vitamin D content of egg yolk has a vitamin D content of about 20 units. So just to have 400 units of vitamin D, you may have to eat 20 eggs with yolk, which is practically not possible. So therefore, dietary sources in the natural diet of vitamin D are very, very limited unless we are consuming fortified food supplementation. So only natural source remains sunlight. There are several factors which affect cutaneous vitamin D synthesis, which include skin pigmentation. Indians typically have a type 4 or type 5 kind of a skin, which is a bit darker, which may need a little longer time for synthesis of vitamin D of sunlight exposure. The latitude where we are. So latitude determines the zenith angle. If the rays are coming straight, then the vitamin D synthesis is better. Season and time, it is better in summer, poor in winter. That's also because of the angle of the sun rays. Atmospheric pollution. So if you see polluted cities, the level of vitamin D deficiency would be high. Clothing. Indian culture, typically, we are fully clothed, predominantly indoors. If we are sitting in our offices in the filtered glass, that's of no use. The sunlight coming through our window is of no use because the ultraviolet rays are absorbed in the glass. Use of sunscreens is very common, and that is also one more limiting factor. With older age also, the vitamin D synthesis goes down because the precursor amount, the substrate that is available for vitamin D synthesis goes down. So we do not typically have a sun-seeking behavior. We have a sun-fleeing behavior, and our clothing and our predominant indoor stay puts us at more risk of vitamin D deficiency. This is a diagram or from a study which shows the effect of type of skin. So if you have a lighter skin, if you have a more fair skin, so to say, you need lesser amount of sunlight exposure to produce the same amount of vitamin D. The second diagram on the right side shows the impact in terms of summer versus winter months, that the vitamin D synthesis and also the timing. So the sunlight, this is often question asked whether morning sunlight or evening sunlight. Actually, it is the afternoon sunlight or sunlight typically between 11 to 1 or 10 to 3. That is the sunlight which is more useful for vitamin D synthesis. Coming to the prevalence of vitamin D deficiency in Indian children. Let me quote some studies for this. So now whenever we are seeing prevalence studies, if somebody says 80%, 90%, we must ask what was the cutoff used for defining vitamin D deficiency. And this is one of the challenge in determining prevalence of vitamin D deficiency, that there is no mutually agreed cutoff which are used in studies. So cutoffs ranging from 5 nanogram per ml or 20 nanogram per ml have been used in several studies. So in this particular study done in two kinds of urban and lower socioeconomic strata schools in northern India, that is Delhi, showed that about 35% of children had vitamin D levels of less than 9 nanogram per ml, which is clearly severe deficiency. And the typical cutoff that is used of 20 nanogram per ml, nearly 85 to 90% children had levels less than 20 nanogram per ml. Another study from Professor Anju Seth in Lady Harding. This is 180 exclusively breastfed infants and their mothers. So 25D of severe deficiency, that is less than 10, was found in about half of the mothers and 43% infants, where only 9% infants had levels more than 20 nanogram per ml. In a study from Lucknow, near Lucknow, rural northern India, 88.6% adolescent girls had levels less than 20 nanogram per ml. And similar studies have also been documented from southern India and from Pune in Maharashtra. So about 70-80% girls, adolescent girls, were documented to be vitamin D deficient using a cutoff of 20 nanogram per ml. Now, the government data that has been released from the Ministry of Health and Family Welfare uses a cutoff of 12 nanogram per ml. It was found that about 14% children aged 1 to 4 years, 18% among 5 to 9 years, and 24% among adolescents were vitamin D deficient. So as you can see, depending on the cutoff used, the prevalence of vitamin D deficiency can change. Now, who decides these cutoffs? How do we know that 12 is enough, or 15 is enough, or 20 is enough, or what? Why is there so much controversy about it? Because initially it was known that vitamin D deficiency causes rickets and osteomalacia. And for preventing rickets, a level of 12 nanogram per ml is good enough, or less than 12 nanogram per ml. However, some studies document that rickets can happen between levels of 12 to 20 nanogram per ml, especially in the presence of poor calcium intake or very high intake of phytates in diet, which is common in Indian vegetarian diet. So rickets can still develop at these levels. Other parameters that can be used are normal alkaline phosphatase. However, this is not a very sensitive or specific marker for vitamin D deficiency. In most studies, the parameter that has been used is PTH. So at which point the PTH starts rising. That is the biological response to vitamin D deficiency. And but here also researchers differ as to what is the cut point where the levels of PTH start rising in vitamin D deficiency. There are other factors like bone mineral content or density, calcium absorption rates, or fracture rates, which are not really very well studied in children. So what is the cutoff to define vitamin D deficiency? Now, whenever we are estimating vitamin D levels, 25-hydroxy-D is the most stable compound and has a good half-life. And therefore, that is the best parameter to assess vitamin D status. And it is also important to know what is the method with which we have estimated, because the immunoassays, which are most commonly available, can detect several other compounds, which may not reflect the actual level of D2 and D3. They also, they are not specific for D2 or D3. They measure both these compounds, and plus other components like 24-25-hydroxy-D. So the liquid chromatography using ultraviolet spectrometry or tandem mass spectrometry, that is the most specific or more reliable assay. However, this is not yet available in many centers. It is just becoming available now. Over a period of next few years, probably we'll be having more of LCM SMS assays for vitamin D and other hormones also, which has more reliability than the immunoassay. So the IAP has given guidelines in 2017, and I'm sorry, this is 2021 December, but probably it will be in print in 2022. So it defines vitamin D deficiency as levels less than 12 nanogram per ml, based on the pretext that as of now, the main purpose of vitamin D is to prevent rickets and osteomalacia. However, it also says that just to tide over a period of, for example, winter season, stress, illnesses, etc., a level of up to 20 is desirable, and more than 20 would be considered as sufficient. The US Endocrine Society, which is not a specific guideline for pediatric per se, it is a common guideline for pediatric as well as adult, defines deficiency as less than 20 nanogram per ml, which is also given in the LIPS classification, which is used in many research studies, and 20 to 30 as insufficient, and more than 30 or 30 to 100 as sufficient. Now, this level of 30 has not been well studied in children. So in adults with osteoporosis, etc., or existing bone conditions, it may be desirable to keep that kind of a level. But in children, it may be enough to keep the vitamin D level just above 20. There are few studies where a U-shaped relation has been documented between vitamin D deficiency and fractures. So levels more than 50 nanogram per ml, we don't know what is the benefit. So I typically do not encourage taking the levels to, just because the normal range has been mentioned in US guidelines is 30 to 100, we want it to be close to 100, nothing like that. So I typically avoid taking it more than 50 nanogram per ml because the benefits are not known. All these units are nanogram per ml. Remember that Indian laboratories report in nanogram per ml as well as nanomole per liter. So if you want to convert nanogram per ml into nanomoles, you have to multiply by 2.5. That is the multiplying factor. Nanomole, for example, Lalpath is one of the most commonly used lab in Delhi and North India. It reports in nanomole per liter. And there you'll have to divide by 2.5 if you are converting it to nanogram per ml. This is important to remember. So when do we actually measure? When should we measure vitamin D levels? Ideally, only for cases of rickets and osteomalacia, and infants who have manifestations like hypocalcemic seizures and dilated cardiomyopathy, evaluation of hypercalcemia. Other than these, children who are at risk for vitamin D deficiency and its musculoskeletal consequences. So those children who are on drugs, which can cause vitamin D deficiency, cancer patients, transplant recipients, children with cerebral palsy who are predominantly indoors, or children having systemic diseases like celiac disease, juvenile idiopathic arthritis, inflammatory bowel disease, chronic kidney or liver disease, and diseases with extensive cutaneous involvement. These are the conditions which put children at high risk of vitamin D deficiency, and therefore the levels should be measured in these conditions. It is not recommended to screen each and every person coming to you for vitamin D. It is not recommended to test vitamin D for non-specific conditions like poor weight gain or constipation or ear pain or tinnitus or these kind of conditions. So as of now, we should restrict vitamin D testing to these conditions. If it is not feasible to do the testing, and if we feel that the child is at risk of vitamin D deficiency because of these illnesses, if the child is very poor, cannot afford tests, we can give maintenance of vitamin D without testing, a small dose, usually 400 to 600 units, not more than that. But calcium testing is important in this, because if the calcium is high, then there could be a possibility of hyperparathyroidism or background vitamin D toxicity. I prefer to estimate the levels of vitamin D in those who are on maintenance therapy for vitamin D.
Last year, 2 years, I have done Bollywood quiz, then academic
sir,
quiz.
please unmute yourself. Dr. Bhandarkar sir, unmute yourself.
Premier League, PPL. So bowler आता था.
Hello, Dr. Bhandarkar sir, please unmute yourself.
Then we done for the West Zone, Maharashtra, Goa, Gujarat. उनका भी academic किया और Bollywood भी किया. Then we done for the IMLE, that is a medical legal group. उनके लिए भी किया. So I have that master both. Hemant and Dr. were I prepared the question.
I will request Dr. Jay, please mute yourself. Otherwise, I will request host to please mute Dr. Jay Kumar.
Fun way of learning.
Akshita madam, unmute him.
Done.
Yes, yes.
Sorry for that.
Sorry, sir. Please continue.
No
sorry, sir.
So, as I said in the beginning itself, that 125 dihydroxy is the active form of vitamin D. And sometimes we accidentally write vitamin D levels and the labs do this 125 dihydroxy. It's a very costly test. We should limit it to only selected indications where we are suspecting resistant rickets or hypophosphatemic rickets, or selected cases of hypercalcemia where we have ruled out hypervitaminosis D and primary hyperparathyroidism. Other than these, routinely, there is no need of testing 125 dihydroxy D.
Sir, just a query, sir. In adults also who are diabetic, hypertensive, only 25 hydroxycalciferol to be done test?
Yes. Yes.
Only that to be done. Okay.
Yes. So in now talking of prevention of vitamin D deficiency, the strategies to prevention are quite obvious, like encouraging sunlight exposure. I will not be talking too much on maternal supplementation. As of now, most of the adult physicians or gynecology or obstetric colleagues supplement pregnant women from second trimester onwards. So first trimester, the safety is not known. So first trimester, pregnant women should not be supplemented. Second trimester onwards, they are given 2000 units per day in most of the centers who are giving maternal supplementation. The current Indian pediatric guidelines do not recommend maternal supplementation. However, there can be controversy on that. I haven't yet read any letters to editor, etc. But the Indian pediatrics latest guideline do not recommend maternal supplementation. But most of my adult endocrine colleagues and the obstetric colleagues supplement in the second trimester onwards 2000 units per day, considering very high prevalence of vitamin D deficiency in pregnant women. Food fortification is also one of the strategy, and pharmacological supplementation. Let us talk about each of these briefly. Now, as I've said, sunlight exposure between 11 a.m. to 1 p.m. or 10 a.m. to 3 p.m. is the most effective one, and light filtered through glass is not effective. However, the exact duration and amount of sunlight exposure is variable based on age, skin type, and several other factors that I discussed in the previous slide. Roughly, a body surface area estimation, if we are exposing face, forearms, hands, lower legs, and feet, that constitutes about 40% in children under 5 years and about 30% in adolescents. One of the review by Professor Harinarayan documents that 30 to 45 minutes of daily sunlight exposure of over 12 to 18% of body surface area as sufficient to maintain vitamin D levels in the Indian population. However, this is a very important or very useful study done by Professor Marvaha, where children, the adolescent children, school children, were exposed to sunlight for half an hour every day, and the sun exposure was measured using the solar meters in north, northeast, south, and western part of India. And it was seen that the maximum sunlight exposure or maximum UVB exposure happened between 11 to 1 p.m. And it was higher in the northern India, which are clearly like more hotter climates than the other parts of India. And the parameter, this study happened during the winter months. And actually, despite of this much of sunlight exposure, the vitamin D levels went down in the winter. So they were significantly low from a baseline of 6.3 to follow-up of 5 nanogram per ml. So there was no increase despite of sunlight exposure in the winter season, emphasizing the need for vitamin D supplementation during winter season.
So what was on y-axis on that graph? On y-axis, what was it? What is this y-axis? 0, 1, 2, 3, 4?
Yeah, this is the cumulative ultraviolet exposure.
Okay.
Yeah.
Okay.
Now, this is another study done in infants, breastfed infants, on 100 mother-infant pairs. And about 90% of them had vitamin D levels of less than 12 nanogram per ml. And the sun exposure was documented by the mothers in a sheet. And subsequently, they studied the correlation between sun exposure and vitamin D levels. And with the help of what is called a sun index, which is basically a product of the body surface area that is exposed and the minutes of sunlight exposure per week. So what they found basically was a significant correlation between sunlight exposure and serum vitamin D. This sunlight exposure was not done in the first 6 weeks. It was done after 6 weeks of the infancy. And afternoon sun exposure about 30 minutes per week for 16 to 18 weeks. Starting from 6 weeks, of over 40% of exposed body surface area could achieve sufficient vitamin D levels at 6 months of age. Again, this is a matter of debate, discussion. This is just one study. It may not apply to the whole population, but I thought that it is important to share these studies. With respect to food fortification, this is a study by Professor Khadgawat from All India Institute, which documented that food supplementation is feasible. If milk is fortified with about 600 units per day, nearly 70% of adolescents were having a level of more than 20 nanogram per ml from a baseline of 4.9 nanogram per ml. With 1000 units from a baseline of 12%, 81% adolescents achieved a level of more than 20 nanogram per ml. However, in these studies, we must remember that whenever we want to achieve a certain higher level, there will be a small population which will be exposed to a potential risk for hypercalciuria or vitamin D toxicity also, because we are just shifting the normal distribution curve right side. With respect to supplementation, I'll be quoting verbatim from the Indian Pediatrics Guideline. So by now, I think most of us have understood the importance of vitamin D supplementation for infants, because neither are they exposed adequately to sunlight, nor are they receiving any, I mean, obviously we have a policy of exclusive breastfeeding. So therefore, the breast milk may not be enough source for vitamin D. And therefore, routine vitamin D supplementation is recommended in the first year of life in the dose of 400 units per day. Very high doses can potentially result in toxicity, and therefore we should limit as of now to 400 units per day. The same dose applies also to preterm babies, although we can achieve the higher levels faster using 800 units, but the benefit of that is not known as of now. The Indian Pediatrics latest guideline do not recommend supplementing vitamin D during childhood and adolescence. However, I beg to differ here, and we must do some individual risk assessment, especially in adolescence. In prepubertal children, I know that there is no evidence to supplement vitamin D and see its benefit, not enough evidence. But in adolescents who are having minimal or negligible sunlight exposure, I think we might consider giving a small supplement of vitamin D, like 400 units per day or something like that. Now, let us go through some case scenarios to understand treatment or evaluation of vitamin D deficiency in children. So this is a 1.5-year-old male infant. You may want to type in chat box some of the responses to the questions that I asked, so that it becomes a little interactive at least. Now, this boy has presented with bowing of legs. He's breastfed. The breastfeeding has been continued. As of now, no top milk is being given to the child. Some solids are being given, but predominantly on breastfeed. No systemic illnesses. And this is what you see. So you can see in this picture that wrist widening is actual spreading of the wrist. Sometimes in toddlers, you may see a little dip here, but that is not actual wrist widening. Wrist widening is you have to see these bulges on the other side. And in this diagram, or in this picture, you can clearly see the rachitic rosary, this bleeding that you see along the costochondral junction. So what would you do? Would you investigate, or would you straight away treat this child with vitamin D? Maybe I'll wait for a few seconds for any answers. I don't see.
Akshita, if any answer coming, please post here.
Okay. There may be a temptation to treat this child straight away.
Basic investigation should be done.
But I would say that we should at least try and document an X-ray.
Okay.
In this X-ray, you can see the features of rickets, extensive rickets, in the form of a formation of a cup. You can see here, this is the best appreciated in the ulna. Ulna is the fastest growing epiphysis for us, basically in humans. So the best changes are appreciated in the lower end of epiphysis. So if there are any postgraduates attending, if the examiner asks you which is the bone, single bone that you would see for changes of rickets, that is the lower end of ulna. And you can also see the changes in the tibial epiphysis, cupping. The splaying is the widening, and the irregularity, the hazy margin that you see, is the fraying. And also you can see the cortices are very thin and almost looking osteoporotic. Also, you can see these lucencies under the metaphysis. That is because of accumulation of unmineralized osteoid. And at least a fasting calcium phosphorus alkaline phosphatase should be documented in all cases. I know that vitamin D PTH tests are costly. It may not be possible to do these tests in every nutritional rickets, but we should have X-ray and this basic biochemistry, calcium, phosphorus, alkaline phosphatase. And obviously, if the patient or if the family is affording, we should try and document the vitamin D levels at least. So in this case, you have slightly low normal calcium, low phosphate. Low phosphate is the hallmark of all types of rickets except for rickets of renal failure. So that is the main abnormality in rickets. That is what causes irregular apoptosis and the rachitic changes. Calcium is maintained normal by secondary hyperparathyroidism. So when we have high PTH in such cases, there is no need to investigate for parathyroid tumor or any such thing, because this is a compensatory mechanism to the vitamin D deficiency. And alkaline phosphatase is a bone turnover marker. It just indicates the state of bone turnover. So you have low normal calcium or normal calcium in nutritional rickets, low phosphate, high alkaline phosphatase, low vitamin D. So this is nutritional rickets. Is it necessary to document vitamin D level in a typical nutritional rickets? I have just said that it is not mandatory. You can just document calcium, phosphorus, alkaline phosphatase, and X-rays, but it is desirable. Obviously, I mean, if we can do it, we should do it. Coming to the treatment of this child, how do we treat this child? If we go by the Indian pediatrics recommendation, which are also in line with the global consensus recommendation, which were published in 2016, vitamin D deficiency rickets has to be treated by giving vitamin D and calcium. So both vitamin D and calcium are important. It is not that we have to give only vitamin D. Now, daily supplementation is preferred over intermittent dosing, because it gives a more stable and more sustained level and also minimizes the risk of toxicity. So wherever compliance is ensured, we should try and give daily supplementation. Under 6 months of age, we should compulsorily give daily supplementation and not intermittent dosing. More than 6 months, 6 to 12 months, 2000 units per day for 12 weeks or equivalent dose on weekly or monthly basis. So either like 60,000 units once a month for maybe 2 or 3 months. And for more than 1 year, 3,000 units per day or 60,000 units fortnightly for 5 doses, not more than this. So no 6 lakh unit, no daily for 10 days, no weekly for 10 weeks, no daily for 10 days and then weekly for 10 weeks, no injection of 6 lakh unit. These doses must be avoided because there is no need of these doses. Rickets can heal with lower doses, and there is a potential risk of toxicity with higher doses. All these children have to be supplemented with maintenance dose of vitamin D after the treatment has been completed, as long as they remain at risk for vitamin D deficiency subsequently. We have to ensure a daily calcium intake of 50 to 75 milligram per kg per day. In the active phase, we should give this as a pharmacological supplementation. But after that, we should try and encourage the increase intake of milk and milk products to meet this kind of level of calcium intake. How do we monitor the treatment of this child? We typically do radiographs at 4 and 12 weeks to see for evidence of healing. And at the completion of treatment, we try and document calcium, phosphate, alkaline phosphatase, and 25-hydroxy-D. If there is hypercalcemia or hypervitaminosis D, we also document urine calcium creatinine. I'm sorry, this should be creatinine, and ultrasound of kidney to document presence of any nephrocalcinosis. If there is no improvement by 12 weeks of adequate treatment and compliant treatment, we should evaluate the child for resistant rickets. So no like repeating the second thing. You can refer the child for evaluation of resistant rickets. Remember that improvement does not mean clinical improvement. The bone deformities may take much longer. So therefore, biochemical and radiological improvement is what we are talking about. The bowing of legs or knock knees can get longer to fix or mold. It can take a couple of years also. So just because the deformity is not healing, don't go on repeating the vitamin D doses. See biochemistry and see radiology. So this is the same child, and this is the pre-treatment X-ray. And you can see that whatever irregularity was visible, after a month of treatment, the irregularities has become much less. You can see the line of healing here and also in the lower end of tibia. You can also see that the femur, which was very extensively irregular here, has become more smooth. So this is evidence of healing radiologically. Right at the beginning, one may suspect vitamin D resistant rickets or non-nutritional rickets if we have these parameters, like, for example, consanguinity, familial clustering of cases, evidence of chronic diseases, kidney, liver, malabsorption, presence of alopecia, as in this child, and this child is from Nepal, came with severe rickets and alopecia, this which indicates type 2 vitamin D dependent rickets. Cataract, intellectual disability, failure to thrive, polyuria, recurrent vomiting, that suggests presence of renal tubular acidosis, and history of vitamin D intake with no clinical or laboratory improvement. Other features like jaundice, metabolic acidosis, nephrocalcinosis also point to non-nutritional rickets. Coming to the second case, this is a 10-year-old girl with obesity. She is obese, as you can see, she's 137 centimeters and 60 kg. And they've just underwent some package which had vitamin D test, and the levels were 15 nanogram per ml. She does not have any musculoskeletal symptoms, and the calcium, phosphate, alkaline phosphatase are normal. How would we treat? I often see in my practice that such cases are unnecessarily treated very aggressively by giving 6 lakh unit or weekly for 10 weeks or daily for 10 weeks, 10 days. All that is not required. We must avoid aggressive treatment of asymptomatic cases. Remember, medicine means first do no harm principle. Avoid aggressive treatment of such cases. If we have incidentally detected low serum vitamin D of less than 12 or less than 20 in those who are at high risk, which has been mentioned previously, we can use the same doses that we use for nutritional rickets. The IAP guidelines are silent on what happens between 12 and 20, but I would say that we can supplement them with maintenance doses somewhere between 400 to 1000 units, depending on the age of the child, of vitamin D, to take the vitamin D levels to a safe range of, let us say, 20 nanogram per ml. If we are supplementing for long term, we should intermittently document calcium and vitamin D levels. At least what I do is, if the child is on supplementation for more than a year, once in a year, I get calcium and vitamin D levels checked. We did a study on school children in Vidyagyan school in Bulandshahr in Uttar Pradesh, where we screened 100 school children of a particular grade for vitamin D deficiency, and about most of them, actually nearly 90% of them, had levels of less than 10, and almost half of them had levels of less than 10, that is severe deficiency. And we gave them a monthly dose of 60,000 units, and after after 10 doses for up to 10 months, the vitamin D levels were again done, and about 70% of them went to more than 30. So monthly dose supplementation was effective. We need not treat them with aggressive doses of vitamin D. Remember that whenever we are supplementing this monthly kind of a dose, the safety of more than 6 months or 1 year has not been well studied. So therefore, don't, even like once a month dose also, we shouldn't give for more than a year or something like that. Coming to the next case, this is a 2-month-old infant with first non-febrile seizure, first episode of non-febrile seizure. And the biochemistry, glucose was normal, calcium is low, 5.5, phosphate is 6.8, slightly on the upper side of normal or above normal, with a high alkaline phosphatase and high PTH, magnesium being normal. What is the diagnosis? Again, I'll wait for the chat box. For a few seconds, maybe 5-10 seconds. So this is typically late onset infantile hypocalcemia or hypocalcemic seizure. And in these kind of cases, in late onset neonatal hypocalcemia or infantile hypocalcemia, we should document vitamin D levels. I would refer you to this very nice study done by Preeti Mehrotra from Lady Hardinge Medical College, where 90% of infants with hypocalcemic seizures had vitamin D deficiency. That's the most common cause of hypocalcemic seizures, late onset hypocalcemic seizures. And remember that in infants with vitamin D deficiency, the serum phosphate level sometimes can be high also. So therefore, these children should not be misdiagnosed as having pseudo hypoparathyroidism, because they have low calcium, high phosphate, and high PTH, which is typical biochemistry of pseudo hypoparathyroidism. But actually, in practice, they have just vitamin D deficiency. Coming to the next case, 2.5-month-old female infant presented with cardiac failure following a minor respiratory infection and was found to have dilated cardiomyopathy. On investigation, she had hypocalcemia and severely low vitamin D levels. Just the correction of vitamin D over a period of time led to complete normalization of LV ejection fraction over the period of 8 months. In literature, it has been documented that this can take up to 10 to 16 months also, normalization of ejection fraction. But this is a reversible cause of dilated cardiomyopathy in infants. So whenever you see infant with dilated cardiomyopathy, please document calcium levels and vitamin D levels, because this is totally curable cause. These children should not die. Next
How
case.
both were treated? How both cases were treated? How much of vitamin D?
Sorry?
How was it treated?
The treatment will be same as what we discussed during the treatment of nutritional rickets.
Okay.
Treatment guidelines will be same. The only difference in case 3 and case 4 is that when you have such severe presentations and when you want to rapidly normalize the calcium levels, we should use active form of vitamin D. That is the role of active form of vitamin D, or rocaltrol or calcitriol, in vitamin D deficiency. So along with IV calcium, initially they will need IV calcium, and then you start calcitriol and oral calcium to normalize the calcium rapidly. Here, one of the misconceptions that people have is that injection of vitamin D will lead to better or faster increase of vitamin D levels than the oral dose. In contrast, it is the opposite. Injection is the one which causes very slow absorption and rise of vitamin D level over a period of few weeks, whereas the oral vitamin D levels rise quicker. So therefore, in terms of vitamin D, oral versus injection, the oral absorption is faster as compared to the injectable absorption. So this is one thing to be remembered. In seizures and in dilated cardiomyopathy, for the first 5 to 7 days, you will have to use calcitriol in the dose of usually 20 to 50 nanogram per kg per day to normalize the calcium rapidly. So you start with IV calcium, you start with calcitriol, and then oral calcium. If the child is sick, then sometimes we have to give the calcium through the nasogastric tube or orogastric tube, and then taper the IV calcium under the cover of calcitriol and oral calcium.
Oral calcium, any elemental calcium per kg body weight? Because I missed some of the
As I said, 50 to 75 milligram per kg per day.
Okay.
Now, these kind of cases I have seen in the past year very often. This has happened typically after COVID lockdown. 10-year-old girl with waddling gait, noted recently, with a lot of pain, proximal weakness, poor sunlight exposure during the COVID lockdown because the schools were closed for a very long time, and poor milk intake. No systemic disease. Again, similar biochemistry with low calcium phosphorus, high alkaline phosphatase, and very high levels of PTH. And typical rachitic changes that you would not usually see in adolescents. So we have seen several adolescents coming with severe vitamin D deficiency. We've had 10 or 15 ICU admissions with tetany and seizures, just vitamin D deficiency during the COVID lockdown time. So this is one study from Italy where the pre-pandemic and pandemic levels of vitamin D were studied. This is a retrospective study. And it was found that only the pre-pubertal children, those who are not going to school, they didn't have any difference pre-pandemic or post-pandemic. But the school-going children had a decline in vitamin D levels, which was statistically significant. So we have seen this in clinical practice in terms of significant increase in cases of tetany, seizures, and osteomalacia in adolescents. We also, because we are on vitamin D and COVID, we did a study in 2020 during the first wave of COVID, where we studied association between vitamin D, because there was a lot of talk on vitamin D and COVID, but we did not find any association of vitamin D levels with the COVID severity, mortality, or any of the other factors like oxygen or ICU admission in Indian patients hospitalized for COVID-19. This study was not pediatric study. Another case, I have seen this case long back. This is a adolescent boy who was actually referred to neurology department for NCV, and he was dead scared of getting the NCV done. So then they kind of had referred for a second opinion, and he had typical manifestations of osteomalacia. And this is a bone scan showing increased uptake in metaphysis and pseudofractures in ribs. And you can see this pseudofracture because there is no actual loss of continuity of the cortex. So you can see this pseudofracture in the left pubic ramus. Left pubic ramus or the femur bone, these are the common areas where pseudofractures are seen. So if you want to see osteomalacia cases, you should do an X-ray of the pelvis in addition to the wrist X-ray that we typically do for rickets. Probably last case, 3-month male infant. Parents are concerned about poor weight gain. And they were prescribed vitamin D drops for poor weight gain by pediatrician. He presented with fever, dehydration, hypotonia, and altered sensorium, and a calcium level of 18 milligram per deciliter. So hypervitaminosis D is a result of inadvertent administration of large doses, repeated doses, injectable, as well as it can be seen with oral vitamin D excessive doses also. Typically, levels more than 100 nanogram per ml have high risk of toxicity, and more than 150 nanogram per ml have a very strong risk of hypercalcemia. Now, this is a devil which can show its manifestations after a long time, because the nephrocalcinosis can lead into renal failure after a long time, or something like aortic stenosis can happen after a long time. And pancreatitis, etc., can happen even in a short time, like hypercalcemia can cause pancreatitis. So what are the common reasons for toxicity? Firstly, inappropriate prescriptions. There are some absurd prescriptions like 6 lakh unit injection weekly, not typically by, pediatricians don't write such doses. But we also see a lot of over-treatment of moderate cases or mild cases where just because you see a dark number in the lab report, you kind of give these 6 lakh units. So inappropriate prescriptions of excessive vitamin D for vague symptoms or vague musculoskeletal symptoms, misinterpretation of prescription instructions, continued high dose administration by parents, duplication of prescription. So 3 doctors have written 3 different brands and patient is taking everything. And what is also important is look-alike, sound-alike medications. What is the meaning of look-alike, sound-alike medications? You write something and the pharmacist dispenses something which is similar. So Depura Kids, Depura 60K. Sometimes the pharmacist can go, or whatever there is available can be given to the family. D-Rise 2K, D-Rise 60K, Uprise D3 2K, 1K, 60K. So you can take every single brand and you will have all these kind of things, which is somehow, I don't know why Indian pharmacy is allowing these kind of things, but these are dangerous. So therefore, I always make sure that whenever the patient I've written vitamin D, I ask them to get it to me and cross-check if the correct dose of vitamin D has been dispensed by the pharmacist. Also, there is high degree of variability in vitamin D3 content. Dr. Khadgawat from AIMS did a study where they analyzed lots of brands of vitamin D, and they found that only 28% of the brands were within the accepted range of vitamin D. The percentage variation in commercial preparation of vitamin D3 content varied from minus 91% to 65%. So some of them didn't have any vitamin D at all. This variation can lead to undertreatment as well as vitamin D toxicity. How do we treat vitamin D toxicity? We first stop any further vitamin D or calcium. Sometimes we have to stop all milk and milk products if the calcium levels are high, and give a low calcium diet. Frequently monitor the calcium and urine calcium creatinine ratio. For significant hypercalcemia for levels more than 12 or 13, you might have to admit because the dehydration may not be apparent. So you give normal saline 1.5 to 2.5 times the maintenance with or without loop diuretic. Glucocorticoids, because prednisolone reduces the intestinal absorption of calcium. So prednisolone in the dose of 1 to 2 milligram per kg per day, given as divided doses. Actually, I don't give it every 4 hours. I give it once or twice a day only, like for 2 weeks, and then taper gradually over a period of 1 month or 1.5 months. Because remember, vitamin D is a fat-soluble vitamin. It stays in the body. So therefore, it may take 2-3 months for the effect to go off. So for those 2-3 months, you have to be really vigilant. in some cases, you may require more aggressive treatment like calcitonin, bisphosphonates, or dialysis. Coming back to case 6, this child was actually getting a prescription, a preparation which had 200,000 units per day daily. So, I mean, he ended up in a bad shape because of this. So to end my talk, I would say that there is higher awareness of vitamin D deficiency, and vitamin D deficiency is indeed a public health problem in India, despite of abundant sunshine. Levels less than 12 nanogram per ml is considered as deficient, whereas more than 12 nanogram per ml is sufficient vitamin D. We mustn't aggressively or over screen for vitamin D levels because the benefits of such screening are not known. No stoss dosing and no mega dosing of vitamin D for any condition. Vitamin D is a drug. It is not just a vitamin which you can just administer left, right, and center, and it is potentially toxic. So use carefully. We don't know what are the benefits of giving vitamin D in non-skeletal conditions. So it may be desirable to keep the vitamin D levels in a safe range like 20 or just above 20. But we need not have to aggressively treat these conditions with vitamin D. Thank you.
Thank you very much, sir, for such a wonderful and crisp presentation. Really, it was very enriching about the vitamin D, and we came to know the lot many things about vitamin D. Especially the afternoon sunlight of 10 to 3 is most important, and less than 12 nanogram per ml of vitamin D level is considered as deficient. So moving on towards the question and answer session, there is a question in the chat box, sir. I would like to ask that. Dr. Raj Mehta asked about the routine vitamin D supplementations, especially mega doses in case of atopy or allergic rhinitis.
Yeah, I wouldn't encourage use of mega doses for atopy or allergic rhinitis. As I said, that if one wants to keep vitamin D in the safe range, one can give a maintenance dose of vitamin D if the child is at risk of getting vitamin D deficiency. There are studies which say a slightly higher risk of acute respiratory infections in vitamin D deficiency. Also in pneumonia, vitamin D levels, vitamin D may play a role in ciliary dysfunction and the musculoskeletal, but all these problems are largely secondary to the rickets part of it. So therefore, as of now, the role of vitamin D is predominantly limited to musculoskeletal system.
Okay, sir. His second question already you had covered that he has asked in many viral infections, children are getting sick. Is there a role of vitamin D deficiency? You had answered already. Sir,
there may be a role of vitamin D deficiency. It is just that we don't know whether giving vitamin D deficiency will reduce these infections.
Yes. Yes, sir. Sir, I would like to ask question that in the topic you had said that there is a risk, there is a vitamin D reducing the risk of multiple sclerosis and all that type 1 diabetes, then Crohn's, and reducing risk of severe illnesses, and it's supporting immune system. But I would like to ask you, sir, are there any recommended doses of vitamin D, especially in these conditions? And how long would you like to give, how many duration would you like to give?
So in all these conditions, the causality is not proven. So therefore, there's no role of routine supplementation for all these conditions.
Okay, sir. Sir, is there any vitamin D appetite suppressant effect that somewhere I had read that it is used for weight loss? Is it true, sir? Or,
no, no, there's no such evidence.
Sir, lot of use of sunscreens nowadays, especially in ladies.
Yes.
Or there are many indoor official work to nowadays. So the sun exposure is less, or in sunscreen the exposure is less. Then dietary food, you had said that there is in your talk you had said that limited vitamin D we are getting from dietary sources. So whether you recommended in this condition the daily vitamin D supplementation or for what duration?
So actually, the natural sources of diet typically consumed in India have very less vitamin D. If we are getting the supplement of fortified milk, etc., then that is obviously taking a drug. Basically, is nobody would want for a normal person, to take a pill every day. In terms of supplementing vitamin D, as of now, infants and probably adolescents who are at risk of vitamin D deficiency because of very low sunlight exposure, I would give maybe 400 or 600 units in a day. In infancy, only 400 units per day. But in older, in postmenopausal women and in there, one would supplement vitamin D maybe once a month, 60,000 units or 2,000 units per day. Or adults who are at risk of vitamin D deficiency, typically they are given doses up to 2,000 units per day or 60,000 units once a month. But so I wouldn't give once a month for children.
Okay.
Just for prevention.
To extend that question, the answer, in adults, most often they use 60K a week, and 60K a week they use. If they use, what are those conditions? And if they use 60K per week, does it require vitamin D level monitoring in what time?
So actually, in adults, obviously the therapeutic window will be, 60,000 weekly given for 5-6 weeks. I think the Endocrine Society recommends 60,000 per week for 6 weeks. That may not cause toxicity in adults typically if it is a oral administration, but that is to be done only for clearly symptomatic or severe cases, not for everybody.
And monitoring after 6 weeks is required?
Not necessary to do the vitamin D levels, but calcium monitoring may be required if you think that there is a overdose or if you think that there is a risk of toxicity.
Means that like normal persons or is really not needed to take the daily vitamin D doses, or once a month will be sufficient?
Well, ideally we should try and get some sun exposure.
Yes,
ideally we should try and do that.
So 11 to 1 is our peak OPD.
Well, 10 to 3.
How to go for a sun exposure?
Maybe keep the OPD under the tree.
There were some prior schools where they are under the tree.
Yeah.
Maybe
in school, it is a different thing. School can have a sports period in that time, like between 10 to 3 or whatever. But practically, sometimes the heat may be too much to kind of, especially in Delhi in peak summers, the heat may be really bothersome. But a small, especially what I have seen in this COVID lockdown period is whatever little amount of sun children were getting in the sun, that was able to prevent these severe cases. So at least little sunlight exposure during the school, during the sports period should be able to prevent this tetany and seizures and these kind of life-threatening, painful conditions.
Really, sir, then as you had said, vitamin D is a drug and it has to be used carefully, not routine daily.
Certainly.
Any more questions? Neha, you want to ask any question?
There is one before Dr. Neha asks questions. Probably when we give vitamin D as well as calcium. So calcium syrup, calcium preparation also contains vitamin D, and vitamin D also we are giving. So both those to be calculated and then given probably 400 IU. Am I right? If given.
Well, most of the calcium supplementations, they have very small dose of calcium. They have vitamin D, 200 IU or something like that in 5 ml. So while you are in the treatment phase, that kind of small dose may not make much difference. And beyond treatment phase, typically I would like to encourage intake of milk and milk products to meet the calcium intake.
Okay.
One of the pediatric preparation contains 2,000 units, 1,000 units or 2,000 units per 5 ml.
Yeah.
So whether it is recommended in the pediatric age group after infancy?
The 2,000 units of vitamin D?
Yes, per 5 ml.
Not as a maintenance or not as a prophylactic dose.
Okay. Yes, Dr. Neha.
Yes, over to you, Dr. Neha, for a vote of thanks.
No, if she has some questions, if she wants to ask
If you have some questions, you can ask before that.
Thank you, ma'am. I have a question, sir. So, like we are in mostly we stay in the ACs and all, and we don't have that exposure of sunshine. Even our kids also don't have. So it's better to take a vitamin D supplement and give them also the kids than to be in the sun for so long. What do you suggest?
Nature didn't want us to be sitting in the ACs and in our rooms.
Okay, sir.
So, I mean, in children, particularly in prepubertal children, benefits of supplementation are not known. So therefore, I wouldn't, I mean, if there is anything which can cause potential toxicity, and if I know that maybe 1000 unit works and doesn't cause toxicity, I would still be careful and give a little lesser dose than that, because I mean, I wouldn't want to take chances with making a non-sick person sick.
Thank you, sir.
So we have to be aware of both. Deficiency also is a problem, and toxicity is increasingly becoming a problem.
Thank you, sir. We all know that vitamin D, also known as sunshine vitamin, is a fat-soluble vitamin. Its deficiency may occur from lack of diet, food absorption, or having any metabolic...
One minute, Dr. Neha, 1 minute. We have raised that question, fat soluble. Now there are also preparation which are say that is a water soluble. So does it really make the difference of water soluble and fat soluble?
So the nanoparticles,
yes.
there is one study again by Professor Marwa, where the micellized form or the nanoparticles raise the vitamin D level slightly better than the fat soluble forms. So with respect to the fat soluble forms, for example, the sachets that we give, we have to make sure that it is given with milk, with fat. There has to be some fat along with it. If we give it in water, then it will not be absorbed better.
That is a fat-soluble vitamin.
Yeah. But the micellized forms can be taken without milk also, the nano preparations.
No, they most of the time they are promoted, and we tend to say that the nanoparticle should be given. So what do you say, sir? Which one we should follow? Giving nanoparticles or what to do?
Well, the cost-wise, it increases the cost a lot. So because the sachet costs about 15-20 rupees, and the nano thing costs about 65 rupees per bottle.
Okay.
So we have to take everything into consideration. Also, like some people have dislike the granules, so they want to take the liquid. As of now, either is okay.
Sorry, Dr. Neha, to interrupt. Please go ahead.
It's essential for all of us, newborns, adults, kids, growing kids, old age group, as well as for in pregnancy, chronic illness, and lifestyle diseases. Also, vitamin D is essential for all. So vitamin D is both a nutrient what we take orally or as a supplement, and it's also a hormone what our body makes. So thank you, Dr. Ganesh Jewalikar, sir, for excellently decoding vitamin D for us today. So you have very well simplified the topic, and with the day-to-day cases also. Thank you, sir. I would like to thank our Maha-IIT President, Dr. Hemant Kangodia, sir, and Dr. Amol Pawar, sir, our Secretary General, State Convener, Dr. Jay Bhandarkar, sir, for organizing today's CME. I would thank Dr. Shunali Sevate, ma'am, for being the moderator. Would thank Catchet Pharma for supporting today's CME. And thank you to all the attendees who have joined us today. Thank you so much.